I have the pleasure of introducing Dr. Shriyukta Bhattarai. Dr. Bhattarai is one of the nephrology fellows at Brown University, working with Dr. Ankur Shah, one of our colleagues. She completed her medical school at Kathmandu University, School of Medical Science, and did her residency at Ohio St. Elizabeth. And today she's going to be talking to us about this important study as part of the PDOPPS series that examined associations between serum sodium, peritoneal dialysis-associated peritonitis, and mortality. Excited for a great session. Hand it over to you.
Yeah, thank you for the nice introduction. Yeah, so we're going to talk about the study association between serum sodium, peritoneal dialysis-associated peritonitis, and mortality in the PDOPPS. Okay, I'm not able to advance the slide. Is the slide advancing?
Yes.
Okay, so the background for this study, we know that PD peritonitis remains a significant cause of morbidity in this patient population. It's a leading reason for permanent transfer of patients from PD to hemodialysis. And previous research on electrolyte disorders have mainly focused on hypokalemia, that hypokalemia is associated with increased peritonitis in PD patients. And we also know that in HD patients, hyponatremia has been linked to increased risk of death. Both hypo and hypernatremia has been associated with increased risk of bloodstream infections in hemodialysis patients. Similarly, in CKD also, we have some data that hyponatremia is linked to increased risk of death. However, the relationship between serum sodium and outcomes in PD patient is less well defined. So the serum sodium in dialysis patient is influenced by multiple factors. One can be diet, free water ingestion, malnutrition, poor solute intake, could be because of the dialysate or could be because of the transcellular shift. We have noted that icodextrin use can cause 2 to 3 milliequivalent per liter decrease in serum sodium. It's because when the icodextrin metabolites such as maltose, maltotriose get accumulated in the body, it can cause isoosmotic hyponatremia. We don't know that the decrease in serum sodium because of icodextrin treated patients carries the same risk as hyponatremia in other patients, which is like hypoosmolar hyponatremia in other patients. So there were a few studies done in the past. I'm just going to cite few studies that I found important. The first one was titled Hyponatremia as a Predictor of Mortality in PD Patients. This was published in 2014, enrolled 441 patients, and a median follow-up was 34.8 months. They did a time average sodium, and time average sodium of less than 37 was associated with increase in all-cause mortality, with a hazard ratio of 3.35, confidence interval between 2.1 to 5.6, and infection-related mortality with a hazard ratio of 3.18 and confidence interval between 1.5 to 6.4 in an adjusted model. It also showed that when you improve the serum sodium, then the mortality goes down. For example, for every 1 milliequivalent per liter increase in serum sodium, the hazard ratio was down to 0.79 for all-cause mortality, was down to 0.77 for infection-related mortality. So this was significant. However, this study did not report the frequency of peritonitis or the relationship between serum sodium and peritonitis. There was another study published around the same time in 2014 titled Hyponatremia is a Surrogate Marker of Poor Outcome in PD-related peritonitis. So this study enrolled 99 patients with PD-related peritonitis. Out of them, 27 patients had sodium of 130, which is 27%. So they concluded by saying hyponatremia, so with sodium less than 130, was independently associated with poor clinical outcome, including high in-hospital mortality and longer length of stay. Likewise, another study published in 2015, which was titled The Effect of Serum Sodium on Survival in Patients Treated by PD in the United Kingdom. So this was also another retrospective observation study. They took 3,108 patients from UK Renal Registry, and the median follow-up was 3.2 years. It said that lower serum sodium concentration, so they defined low sodium as less than 138 in this study, at the start of renal replacement therapy in PD patients are associated with increased risk of mortality with a hazard ratio of 1.49. In this study, there was strong association between hyponatremia and mortality, especially in a younger age group. There was twofold increase in the risk of death, even after adjusting for covariates. There was 3% reduction in mortality for each 3.6 milliequivalent per liter increase in serum sodium. So these were the 3 studies that I looked at. So now it brings us to like what's the rationale for this study, right? So in most of these previous studies, it was small scale. The low sodium was not clearly defined. Some used less than 138 as low sodium, some used less than 130 as low sodium, some used less than 135. So the authors in this study that we're going to discuss today felt there was a need for a large-scale, comprehensive international study to specially explore the association between serum sodium and adverse outcomes such as peritonitis and mortality. And also they wanted to look for the impact of icodextrin. They specifically wanted to test the hypothesis whether variation in serum sodium would be associated with increased risk of peritonitis and death or not. That was the primary objective of this study. However, they also wanted to look if factors like icodextrin use, demographics, PD modality would alter the association. So coming to our study today, so this was a multi-center observation cohort study. Data source was obtained from PDOPPS. So PDOPPS is an international prospective cohort study in collaboration with ISPD. They did it in 2 phases, phase 1 and phase 2. And you can see it in the chart. I got it from the PDOPPS website. So they started enrollment in 2014 and continued till 2022. And South Korea and Colombia were the last countries to join. They did the study across 8 countries and time period between 2014 to 2022 in 2 different phases. So participants, they initially screened 25,423 patients. All of the patients had to have a serum sodium measurement before the study or enrollment, and they excluded patients who didn't have any serum sodium in the 4 months before enrollment period. They excluded the patients who were on hybrid therapy, PD and hemodialysis hybrid therapy. They excluded patients from the facilities where peritonitis is not frequently reported or not properly reported. So in the end, they had 23,588 patients for the primary mortality analysis and 22,242 patients for primary peritonitis analysis. And the median follow-up time period was 12 months, between 6 to 22. So they chose the most recent serum sodium in the 4 months before PDOPPS enrollment, and they categorized the sodium level into 5 different categories. Less than 135, 135 to 137, 138, 139, 140, 141, which is the reference group, and more than 142 milliequivalent per liter. Outcome. So the primary outcome they wanted to look at was time to first peritonitis episode, any organism, and all-cause mortality. Secondary outcome was time to first organism-specific peritonitis episode, whether it is gram-positive, gram-negative, even culture-negative, fungal, or enteric peritonitis. And also evaluate the modification of association by icodextrin use, patient characteristics, and PD modality. They also analyzed the same data using the time average sodium over a 4-month period if they had multiple readings. So for statistical analysis, for peritonitis analysis, cause-specific hazard survival model was used. For mortality analysis, Cox model was used to assess the association between serum sodium and all-cause mortality. Adjustments were made for multiple different things. They categorized into 4 different models. Model 1, they adjusted for demographics, age, sex, Black race, and treatment characteristic, PD vintage, and PD modality. Second, Model 2, they adjusted for 13 comorbidities, which I'll go over later on. Model 3, they adjusted for concurrent lab values such as serum albumin, potassium, phosphorus, magnesium in 24-hour urine volume. On Model 4, they adjusted for diuretics use. So the models were stratified by country, US LDOs, PDOPPS phase 1, phase 2. And for the missing data, I have to mention that there were less than 8% missingness in most variables, except urine volume, where 43% was missing, and serum magnesium. They handled the missing data by chained equation method and did multiple imputation. Also, subgroup analysis was conducted by PD modality, gender, male, female, serum albumin level of less than 3.5, more than 3.5. Patients were using icodextrin use versus non-icodextrin, diabetes, and presence of any residual kidney function. So, baseline characteristics. All right. So, baseline characteristics, I'll go over demographics, comorbid history, dialysis treatment, lab values, and medication use. But I especially want to draw your attention towards the baseline characteristics of patients who have sodium of less than 135. They were mostly females. They were less likely to be Black. They were in PD for the longest period of time compared to other variables. They had the kidney failure for the longest period of time compared to other variables with higher sodiums, more than 135. This patient populations of having sodium less than 135, they had the most number of diabetes, most number of patients with congestive heart failure, most number of patients with hypertension, peripheral artery disease, GI bleeding, lung disease, psychiatric disorders, and history of recurrent cellulitis and gangrene. Overall, the patients who had sodium of less than 135 seemed much sicker than the other group. They were less likely to be on a cycler and more likely to be on assisted PD. Most of them were using icodextrin, and in terms of BMI, they had the lowest, smallest BMI amongst the other group, and albumin was the lowest in this patient population, and they were making the least amount of urine, just 0.7 liter in 24 hours compared to the other group. I wanted to go over this distribution of serum sodium across various countries. It is worth noting that Thailand had the highest number of patients with the lowest sodium. 31% of their patients had a sodium of less than 135, whereas in US, only 12% of the patient had a sodium of less than 135. And distribution of serum sodium by icodextrin use in this overall population, patients who are using icodextrin had the lowest sodium with a mean sodium of 136 compared to non-icodextrin user who had a mean sodium of 139 milliequivalent per liter. Now coming to our key findings, the peritonitis risk. So this is a table showing the risk of peritonitis and with the serum sodium values. And so the 4 bars on the y-axis they are adjusted for like multiple different things. Model 1 is adjusted for age, sex, black race, and PD vintage and PD modality. Model 2, which is orange arrow, is adjusted for 13 comorbidities. Model 3 is adjusted for serum albumin, serum potassium, phosphorus, magnesium, 24-hour urine volume, and Model 4 is adjusted for diuretics use. So this figure shows that we can go one by one. For less than 135 serum sodium, so initially when it was adjusted for Model 1 and Model 2, it seemed like those patients who had a sodium of less than 135 had increased hazard ratio compared to the other groups. However, when we adjusted for Model 3 and Model 4, the risks seems to attenuate. So there was no increase in risk of peritonitis with less than 135 overall. And likewise, for 135, 137, initially when only adjusted for Model 1 and Model 2, it seemed like there was increased risk. However, after adjusting for all four models, the risk seems to attenuate. And so this figure overall shows that there is no increased risk of peritonitis at any sodium level. So this is the subgroup analysis where they did the subgroup analysis for icodextrin use, diabetes, PD modality, gender, albumin, and residual kidney function. So this table shows that there is no increase in risk of peritonitis in any of these subgroups in any of the sodium values. However, it is worth noting that there was significant p-value interaction in the icodextrin use and those who were different modalities of PD, CAPD versus APD. What does this mean is icodextrin use was found to modify the relationship between serum sodium and peritonitis with a p-value of 0.03, which is less than 0.05 and which is significant. But however, none of these reached statistical significance. In icodextrin treated patients, lower serum sodium categories appear to have lower peritonitis risk, and higher serum sodium categories seem to have higher peritonitis risk. But again, like, it didn't reach a statistical significance. So um, when when they looked at the serum sodium and organism-specific peritonitis outcome, again, there was no increase in risk of peritonitis in any of these groups, except in patients with a serum sodium of more than 142, where there is increased risk of fungal peritonitis, with a hazard ratio of 2.23 between 1.04 to 5.43. However, the event rate was really low, like it was just 0.003 events per year. And similar results to the main analysis were observed when the sodium level was averaged over 4 months rather than just seeing just one-time value. Now coming to serum sodium and mortality risk. This is another figure which shows different sodium value on the x-axis and the hazard ratio on the y-axis and adjusted for 4 different models. So this shows that variation in serum sodium were significantly associated with higher mortality. And you see this nice reverse J-shaped curve where there is increased mortality with the lower sodium, and reference range, there is no increase in mortality, and the risk of, like, there is increased mortality again when the sodium is higher, more than 142. Compared to individuals with a sodium level of 140 to 141, if you have a serum sodium level of less than 135, then the hazard ratio is 1.45. Confidence interval between 1.29 to 1.63. If the sodium is between 135 to 137, then the hazard ratio is 1.26. Confidence interval between 1.13 to 1.42. There is no increased risk of mortality in this group 138, 139. and 140, 141 is the reference range. And again, there is increased risk of mortality in patients with sodium level of more than 142, with a hazard ratio of 1.16, between 1.03 to 1.3. And when they did the subgroup analysis, there is again increase in mortality in all these groups. And a group with sodium less than 135, between 135, 137, and more than 142. There was no significant p-value interaction in any of these subgroups. Again, when looking at the averaged sodium over 4 months period, the data was pretty much similar to the primary analysis. There's increased mortality in patients with less than 135, 135, 137, and more than 142 sodium. This is another figure showing the same thing. The blue area is the confidence interval. So for the figure 5A, the most of the area is like crosses 1, so it's not statistically significant. However, for mortality data, it's pretty neat. You can see that there's increased mortality in the both end of the reference range, and it's a nice J-shaped curve. So the key findings overall, variation in serum sodium is not associated with peritonitis risk. And the findings remain consistent regardless of the treatment with icodextrin. Initial model adjusted for demographics and comorbidities showed increased risk of peritonitis when the serum sodium was less than 138. However, when adjusting for model 3 and model 4, the relationship was attenuated. Icodextrin use was found to modify the relationship between serum sodium and peritonitis with a p-value interaction of 0.03, but none of the hazard ratios reached statistical significance for both icodextrin users and non-users. In icodextrin-treated patients, lower serum sodium categories appear to have lower peritonitis risk, while higher sodium categories had increased risk. However, again, this did not reach statistical significance. And results for organism-specific peritonitis were generally consistent with overall peritonitis finding. The only exception is that patients with a serum sodium of more than 142 had increased risk of fungal peritonitis, and with a hazard ratio of 2.83 and pretty significant confidence interval compared to the reference group. However, the authors mentioned that this could be because of the type 1 statistical error, given very low rate of fungal peritonitis episodes. However, if it's a true association, then it could be because patients with more than 142 sodium could be malnourished, may have like multiple comorbid conditions. They could be taking less amount of fluid, increasing them, like putting them at risk for fungal infections. So key findings regarding mortality risk. Variation in serum sodium was associated with higher mortality. There was a good reverse J-shaped relationship found between serum sodium and mortality, meaning both lower and higher levels were associated with increased risk. These associations between serum sodium and mortality were similar across all patient characteristics and PD modality subgroups. And icodextrin use did not modify the impact of serum sodium levels on death risk. So the proposed hypothesized mechanism for mortality impact for those patients who had a serum sodium of less than 135, they suggested that it's possible because of risk of cerebral edema, increased non-peritonitis infections, or impaired cardiac conduction in these patients. We know that mild decrease in sodium are linked to gait impairment, cognitive changes, falls, increased risk of fractures, and more comorbidities in these patients. So that might be playing a role. Low sodium might serve as a proxy for underlying malnutrition and comorbidity, which we saw that these patients had a lot of comorbid conditions compared to the other groups, and they had a lower BMI and lower albumin compared to the other groups. It could be associated with extracellular fluid volume expansion, though like the study didn't have any body composition data. In diabetes patients, hyponatremia could be driven by hyperglycemia, which could be a proxy for poor glycemic control, but we didn't have any data on serum glucose or serum osmolality to confirm that. But anyways, when they did the subgroup analysis between diabetes and non-diabetic patients, they didn't see any difference. So the proposed mechanism for mortality impact in patients with sodium more than 142 could be because of the osmostress, direct cerebral toxicity when the sodium is higher, more than 142 range. And it could also be a proxy for malnutrition, poor access to free water deficit in these patients' population. So coming to strength, this was a large multinational cohort study. Their statistical analysis was very robust, and they explored the effect of icodextrin, which most of the prior studies had not done. Limitation of this study, the first one is this is an observational study. Second is the icodextrin data were limited. They did not include the patients from Thailand because in Thailand, apparently they don't use a lot of icodextrin. And we didn't have the data on serum osmolarity to prove the theory that hyponatremia in icodextrin-treated patient was isoosmolar from secondary to observed icodextrin molecules. Measurement standardizations, we saw variation in serum sodium across various countries. So this poses a question that, was there a difference in assays in these different countries? And exploratory findings, some findings, particularly for organism-specific peritonitis, were exploratory, and multiple testings may have resulted in type 1 statistical error. There was no routine measurement of body composition, and the PD prescription data were not available. The data on serum glucose, serum osmolarities were missing to test this hypothesis of hyperglycemia-driven hyponatremia. So these are the limitations of this study. And finally, key conclusions. The variation in serum sodiums were associated with death, but not peritonitis risk. So the important finding is even subtle change in serum sodium, including levels within clinically normal range, were associated with increased risk of peritonitis. Especially true for sodium level of less than 138, 135 to 138, which we consider it normal, but can have mortality impact in this patient population. So further research is required to understand the mechanism underpinning these associations. And the million-dollar question after this study is, would any intervention to change the serum sodium level have any impact on mortality and overall outcome in PD patients? So that's yet to be explored. So with that, I conclude my presentation and happy to take any questions if you have.
Yeah, no, thank you very much, Shri, for a great presentation. I mean, like you referenced before, I think, I'm getting a lot of similar memories of the investigations into hypokalemia and its association with peritonitis, except, the group in Thailand, once the study was published and showed that association, they went ahead and investigated, right, the effect of potassium supplementation in their patients, right, and did see some benefit in that. But I'd like to turn things over to Joel. I see, Joel, you have your hand up.
Yeah, thank you, Osama. That was a wonderful presentation and a very complicated study. So thank you so much for all your work on this. You know, when we look at the outcome of an intervention and such, you know, we base it on observational studies, which aren't great, the interventional studies that sometimes fall short. But I think one thing that supports it well is the biological plausibility, right? And as you point out, you know, what would the mechanism be, for example, for hyponatremia with peritonitis? Okay, um, with mortality, they made some valid points, but I think one thing that they have a hard time um, really measuring is, as you said, a proxy or a surrogate for something else, like not adherence, right? So we know that most of our patients who are hyponatremic drink too much fluid. And we also know that most of our patients who are not adherent in one aspect of their therapy are probably non adherent in another aspect, right? So, you know, so to me, in a way, I thought just, you know, chasing hyponatremia for peritonitis based on hemo and bloodstream infection without potential biological plausibility that may be there, but we don't know, right? But there's nothing that we know would do that. Makes the study a little bit hard to interpret. I think, and that was commentary. The question I have has to do with residual renal function, because we know patients with residual renal function do better, but they also probably, and I don't know this for fact, and Osama, maybe you know, is that patients with residual renal function have urine volume, and maybe their hyponatremia isn't as common or pronounced. And I found it interesting that they divided the groups up with the lowest group less than 135, which I don't know about you guys, but when I see greater than 135, I'm like, okay, it's the less than 135 that drives me crazy. And why wouldn't we try to look a little bit more detail in those lowest sodiums where maybe the impact would have been more pronounced?
Yeah, so I'm glad you asked that question, Joel, because we have Brian with us here. Brian Bieber is one of the investigators. Brian, or if you wanna help weigh in, he was one of the authors of the paper.
Yeah, great questions, and really appreciate great presentation of the results. Yeah, my background is in biostatistics, so my clinical insight is going to be certainly limited here. Part we were limited in terms of lower sodium levels just by the number. If you look there in the columns, you'll see the kind of the number of patients in each one. I do believe we tried to break that 135 group up, if I remember correctly, into two smaller groups, but just didn't end up having the power to be able to use that in a reasonable manner. You mentioned residual kidney function. That was an adjustment for what it's worth in the models. We were able to adjust for 24-hour urine volume as in places where that was available. I
Could
know
you
that doesn't
separate
completely answer your question, but hopefully it just gives you a little bit more insight.
could you separate out maybe the anuric patients and the non-anuric patients? Was that kind of looked at? I know you adjusted for residual renal function, but maybe the anuric as a group
Right.
would look different.
Yeah, that's a good question. We certainly could have done that. And we do have done that in a number of our other publications, just do that split at patients with any urine function or residual kidney function, those who did not have any. But in this case, we only adjusted for the continuous variable.
Yeah, no, thanks, Brian. Susie.
Yes, I just wanted to make a comment that, clinically, when I see patients with low sodium levels, I tend to think there's something going on acutely or there's malnutrition. And when you look at that albumin in that group, you can kind of see that already they have low albumin. So it seems to me that the low sodium is reflecting some process that's ongoing. And I'm not sure how to attribute some sort of causality related to that directly, other than the fact that maybe they're acutely ill.
Yeah, no, absolutely. I agree. And, a lot of times when you see those J-shaped curves, right? We always say, I mean, even part of the debate for phosphorus, right? Some people say, "Hey, listen, patients who are hypophosphatemic, right? Or, not hypo, but let's say a patient with a phosphorus of 3 may not just be eating well, but we're giving ourselves high fives because their phosphorus is less than 5.5. But if this patient actually had a good appetite and is eating better, right, then the phosphorus is 6, 7, 8. And I remember even, Tom is not on the call today, but Tom Golper, right, he would tell me sometimes, like, Osama, they're healthy, they're eating. That's a good sign, right? And I do agree that it could be a reflection of just the patient's overall well-being. It's kind of like when we look at weight gain. In pre and post dialysis, especially in peritoneal dialysis, which was a study that Joanne did in her patient population, looking at significant weight gain in patients after starting PD. And the question is always, well, if the patient started PD because they were uremic with a poor appetite and had weight loss as a result of it, but then they gained that weight back post PD, this is good weight that was gained, right? This is not just fat that this patient gained. They now have an improved appetite, they're eating more, you are expecting it. So I mean, I even tell my patients, right, you're at your healthy weight now, right? Don't be upset that you gained this weight. This is good. And then Brian, sorry, you wrote in the chat, you mind sharing it with the group just for those who are going to be tuning in and the recorded
Yeah, certainly. There was a question that said, in your analysis of hyponatremia among PD patients, do you identify any associations with exit site or tunnel infections? And I just noted that we did not explore either of those as outcomes in the study.
Got it. No, absolutely. Any other questions, comments? Anybody going to change their practice or, Brian, is there any intention to take that leap to create like a control and intervention group in the future, a la the hypokalemia study in Thailand?
Yeah, we haven't been made aware of anything along those lines as of yet, but would certainly be interested to see if anyone would go that route.
Yeah, no, absolutely. Any other questions, comments?
Yeah, Osama, when I think about the hypokalemia and hyponatremia, I think they're very, very different, right? I mean, there is some biological plausibility for hypokalemia. Hypokalemia can cause decreased GI motility, right? And may reflect poor nutritional status and not eating and all that kind of stuff. So I don't know that we're going to see a host of studies on the effect of electrolytes on mortality and infections. So I think it's a little bit, I don't know that I would use the two together like that, right?
Yeah, no, absolutely. No, I'm in agreement. To be honest with you, initially when it was published and the paper was published, the only parallel, I mean, and Brian, correct me if I'm wrong, because you were in those rooms. I know Jeff and Isaac couldn't join us today, but the assumption was, the biological plausibility. I'm sure Isaac and Jeff didn't really, have some solid connection between the two, but I would assume that that study being on the back of the hypokalemia study was like kind of like thinking, this, we found it with potassium. I wonder if we're going to find this association with sodium too. Was that the thought process that you kind of had? So not necessarily, saying that the process would be the same, but, just seeing if there is an association.
Yeah, that's a great question. I unfortunately don't remember the impetus for starting this research project. But I'm sure, Jeff, if you emailed him, would be happy to have the conversation with you.
But absolutely, Joel, your point is very well taken. I mean, when I initially saw the title, like it raised an eyebrow because like, oh, interesting, like that, that was kind of the the association that was pursued. But we'll get an answer and maybe we'll tag it on at the end of the recording and email everybody to let them know.
There you
I'll
go.
reach out to
I
Jeff.
like that.
He's like, yeah. It's kind of like those YouTube videos that you watch when they record a reaction and then afterwards they're like, well, we now have new information, so we'll have one of those.
Sounds good.
Yeah. All right. Any other questions, comments? I saw Isha Ricky. I'm sorry if I'm butchering the Zoom name, had unmuted for a second. I could have been wrong, but we'll give it a few more seconds. All right. Well, there are no more questions or comments. I'd like to, thank our presenter for a fantastic presentation. Thank you so much, Shri, for joining and for presenting. And thank you so much, Brian, for representing the work group on this. And we'll reach out to Jeff and Isaac to answer some of the lingering questions as well.
Please do. Yeah. Yep.
And I'd like to thank, Susie, Joel, and the rest of the attendees for joining our first session of this academic year. We're on once a month, every month. The website, for those of you who are interested, is fully updated with the dates, the presenters for our time zone and for the other time zones. And, if you want to spread the word or have anybody who you want to or is interested in joining the mailing list, there's also the email for the contact for each time zone as well listed on the ISPD. If you just Google ISPD North America Chapter Journal Club, it'll be there. But I'd like to thank you all so much for joining us and looking forward to seeing you all next month.
Thank you.